I'm at ASH and I'm presenting on response kinetics and factors predicting survival in core-binding factor leukemia. For the purpose of this study, we had patients who were treated on flag-based regimens from 2007 to 2014. So as we know, core-binding factor leukemia is a highly favorable prognostic category which is highly responsive to flag. So flag is a combination of fludarabine, cytarabine, G-CSF, and in our regimens we combined flag either with idarubicin or after the Mylotarg was taken off the market, it was idarubicin, but before that it was Mylotarg. So we had two combinations, which was flag ida and flag Mylotarg. Mylotarg is also flag gemtuzumab. So we had a total of 104 patients, and the patients were equally distributed between the two cytogenetic groups and the two treatment categories. So what we basically looked for in this study was to look at qPCR and how it predicted for relapse and survival among patients who were treated with flag-based regimens. Now there have been studies before which have looked at this, and they did find that qPCR is an important predictor for relapse and survival, but it has not been looked at with flag-based regimens. Among the 104 patients, we had about 96% CR rate. The median log alteration during induction was 2.8, and this roughly translated to a qPCR value of less than 0.1%. So then we looked at those patients who had a qPCR of greater than 0.1% versus those who had less than 0.1%. And what we found was that those patients who had a qPCR of less than 0.1% at the end of induction, that is when they achieved complete remission, hardly had any relapses. So we found that to be an important time point to measure the qPCR. Then we looked at those low responder patients who had a qPCR of greater than 0.1%, and among them we noticed that a rising qPCR over consolidation was again associated with an increased risk of relapse as well as survival. And then we looked at 3 to 4 months from treatment, and again at this time point, if you had measured the qPCR at 3 to 4 months from the start of therapy, there was a decreased incidence of relapse among those patients who had a qPCR of less than 0.1%. Finally, there were 88 patients who did not relapse. They remained in remission at the end of consolidation. And among those patients, we looked at the qPCR value again, and a qPCR value of less than 0.01% was associated with a lower incidence of relapse. Then we looked at whether qPCR is an independent prognostic factor irrespective of other baseline treatment characteristics. And we included age, cytogenetics, the qPCR, and the other hematological indices. And what we found was that it was only the qPCR which was predictive for relapse-free survival as well as overall survival. None of the hematological indices were predictive. So that comes as a major difference compared to previous studies where age and baseline hematological indices are important. In our flag-based regimens, qPCR was found to be the only predictor for relapse and survival. And that's why we advocate that qPCR should be measured among patients during the treatment. And although qPCR is expensive, it is the only important predictor for relapse. So therefore, there should be a cost-benefit analysis when using qPCR in the community setting. So we would advocate for qPCR at a baseline, qPCR after induction, and qPCR after consolidation. And values of qPCR of less than 0.1% at induction, at the end of induction, and a qPCR of less than 0.01% at the end of consolidation should help predict for relapse. And those patients who do have values which do not meet these cutoffs should undergo change in treatment strategy. Thank you so much.